Hi, class. Today we're going to be talking about the relationship between substance use and other kinds of psychiatric conditions or other mental health conditions. And I'm going to start with, in Module 4, with objectives 1 and 2 in this video. So without further ado, let me go ahead and share my screen and get that lecture up. Okay, so as I mentioned, we're talking about the relationship between substance use disorders and other psychiatric conditions. Here are our objectives. We're going to start by describing the terminology, classification, history, and prevalence of dual diagnosis, and then we'll sketch and provide examples for the complicated causal pathways that will explain how dual diagnosis works. So first thing you're probably asking yourself is, what the heck is dual diagnosis? Well, let's get into the terminology, classification, history, and prevalence. First thing is that there are two terms that you're going to hear here. And one of them is a term that's a fairly general, and it's called comorbidity. And comorbidity refers to two or more diseases in one patient. Now, these could be any diseases, any health conditions. Two or more in one patient would be comorbidity. Dual diagnosis is very specific because it includes both a substance use disorder, for example, like alcohol use disorder or substance use disorder, and a serious mental illness in one person. So that concept of having specifically a substance use disorder and a mental health disorder in one person defines the concept of dual diagnosis. Now, I tend to use that term, but you will definitely hear comorbidity floating around. Okay, well, one of the challenges of dual diagnosis is the way that we structure mental health diagnoses in the big book of diagnoses called the DSM-5. So the DSM is the Diagnostic and Statistical Manual of Mental Disorders. That's what it stands for. And it is basically a cookbook of disorders. It tells you each disorder, each mental health disorder, and then it includes criteria for each. What it does is it views each disorder as discrete. So, for example, if a person has schizophrenia, you can look that up and you find the criteria for schizophrenia. But then in another section altogether will be substance use disorder. So if a person has both, the book there doesn't really integrate them together. You've got to look at them sort of separately. And you know, in the history of diagnosis, of dual diagnosis, typically schizophrenia would have been seen as the primary disorder, and then substance use seen as a secondary disorder. And unfortunately, that led to very little treatment for substance use disorder. So now people are starting to see the two on par, but still the question becomes, how do we sort of put these things together, and how do we treat the two of them either sequentially or simultaneously or what? It doesn't help that the disorders are changing quite a bit over time. So as you remember from an earlier lecture, from the DSM-4 to the DSM-5, substance use disorder changed quite a bit, and many of the other disorders change. And in general, the number of disorders is increasing quite a bit from the original DSM, which you can see is quite a thin book, up to the current DSM, which includes over 300 disorders. So that's one of the big challenges for dual diagnosis. Let's get into another challenge of dual diagnosis, which is the history of how it came about. From about the 1960s to the 1980s, there was a process called deinstitutionalization. And let me unpack this a little bit. What happened earlier, prior to the 1950s, is that the drug treatments for severe mental illness were very few. So you had people with schizophrenia, with bipolar disorder, with active psychosis, who were unable to sort of function in society because we did not have some of the medical advances that we have now. And so people were often put into institutions, and they would often live their entire lives in institutions. And that was problematic for a whole bunch of reasons. One was that it a lot of times made people worse rather than better. The conditions in institutions were pretty awful sometimes. And then we start getting these medical advances that will allow us to treat people with drugs and things like that. So there was a major move toward, let's close down these institutions. And most of the state hospitals became much reduced in their inpatient population. And here in Missouri, Fulton State Hospital is essentially a prison. Now, well, what happened with deinstitutionalization is that a lot of people with severe mental illness are leaving the hospitals because the hospitals are closing. But what we didn't do, and what we should have done at the time, was create a support system in the community for people, but we didn't. And so many people with severe mental illness ended up being houseless. And without that housing and being on the street, we all of a sudden got a massive increase in alcohol and drug use. And therefore, substance use disorder and alcohol use disorder increased quite a bit. So we started to see that comorbid diagnosis, the dual diagnosis. Today, unfortunately, we still have the same kinds of problems. We basically got a huge number of unhoused people, or what often used to be called homeless individuals with severe mental illness. And it is very common for these individuals to take up substance use out on the streets and then end up with substance use disorder. They are more vulnerable anyway, and we'll see that with the prevalence data to taking on another disorder like substance use. Unfortunately, what took the place of the mental hospitals were the prisons. So many times people out on the streets with mental illness would commit some small violation. Maybe it would be something like trespassing. They would get arrested for that. And then because of the mental illness, they might, for example, resist arrest or something like that. And then they end up being in prison, and because of the mental illness, committing, repeated infractions that get them in there for longer or keep them in prison. Unfortunately, there's little to no quality treatment in prison, and so we ended up with a lot of mentally ill people in prison, and a lot fewer people in mental hospitals. And you can see that from the graph. So that kind of screwed us over. And now we're ending up with a very high prevalence of people who have severe mental illness and also substance use disorder. So in the US, about 2.5% are going to report both substance use disorder and mental health diagnosis. But of those with substance use disorder, just under half are also reporting other mental health diagnoses. So it's very common to have another diagnosis if you have substance use disorder. And that's the reason we've got a module on this. It's just so commonly do they go together. In terms of treatment, we're kind of behind on treatment. About 52%. So these are just general surveys of the population. About 52% who report being dual diagnosis report no past year treatment for either diagnosis. And only about 7% are reporting treatment for both diagnoses. So they're lucky if they get treatment for one, right? Because over half are getting treatment for neither But most of the time they are not getting treatment for both, under 10% of the time. So we're in a pickle, as you can imagine, where we have, again, a lot of people in prisons, a lot of people out on the streets who have dual diagnosis and who are not getting treatment. Are you surprised at this point in the class that we're seeing such a dire situation? Probably not. Okay. Let's look at comorbidity among those seeking treatment. So the population that comes in for treatment, they're coming in for treatment for a mental health condition, for example, a mood disorder. So this would be depression, bipolar disorder, and the like. About 21% will have a substance use disorder. For persons with anxiety disorders that are coming in for anxiety disorders, about 17% will have substance use disorder. If you look at the severity, because remember there are different diagnostic criteria depending on how many symptoms a person reports of substance use disorder, as the severity of it increases, so does the number of other symptoms of other psychological disorders. So the severity kind of goes together. More severe of one disorder ends up being more severe of the other. So the upshot of the whole thing is that comorbidity with SUD and other psychiatric disorders, psychological disorders is common, and it should be expected in treatment. All right. Well, let's go to objective 2. I want to here to sketch and provide examples for the complicated causal pathways explaining dual diagnosis. So here we're going to take it, okay, they both go together. Now what causes what? And it turns out to be a pretty complicated answer. So we're going to start with a kind of simplified version of it. Here's one thing you may be thinking of, which is that the mental illness causes the addiction, makes you more likely to use the substances, or the addiction causes the mental illness, and those arrows indicate causation. Now, this alone is really difficult to pick apart because it's it's hard to tell sometimes whether the symptoms you're seeing are symptoms of the mental illness or symptoms of withdrawal or symptoms of the substance use. I mean, it's just really difficult to pick apart, even for the basic diagnoses. But then to find out what caused what, oh, that's just a big question mark a lot of the times. And so I want to add a little bit of complication to this and recognize that that's not the only potential there. We could have another thing that causes both mental illness and addiction. And so it turns out that those with mental illness are more susceptible to addiction, and those with addiction are more susceptible to mental illness. And it may be that there's a common factor there. So for example, there may be a genetic vulnerability. So they are genetically sort of primed to have both things. For example, depression and cannabis use disorder, right? So this particular genetic makeup makes them more primed to have both. It's not that the mental illness and addiction are causing one another, it's that another thing is causing both. Another issue is a psychological issue. Impulsivity could cause both things. Delay discounting, which I'll describe in a minute, could cause both things. And then, of course, we have the social factors, and we talked about those quite a bit in the last chapter. Environmental factors like poverty can make one more susceptible toward both things, or lack of a good support system. So it's a pretty complicated causation, and it turns out to be pretty complicated treatment as well. And we'll talk about treatment in the last objective for this chapter, or for this module. Okay, so I want to give you some examples of how this might work. So we'll take the first example is mental illness causing the drug use. So a lot of times people think of mental illness or as being caused as causing drug use, for example, to self-medicate. So if I have a lot of stress in my life, if I have a lot of anxiety, I have an anxiety disorder, I may self-medicate using alcohol. So that would be one way in which the mental illness may actually cause the drug use. Also, mental illness affects the limbic system. And the limbic system is a set of structures in the brain that deal with emotion. And so we do see an effect on the limbic system. That limbic system then connects to many of the reward pathways that we talked about earlier, the nucleus accumbens and things like that. And it may change the functioning of those reward pathways, therefore making people more susceptible to the substance use. So mental illness can cause the substance use disorder. Another scenario is that the drug use can cause mental illness, and we do see evidence of that as well. There's a video you guys would be watching if you haven't already on cannabis use and psychotic symptoms, and it looks like, if you track cannabis users, each year of regular cannabis use as a teenager, so as an adolescent, increase your risk of psychosis, for example, paranoia, hallucinations, by quite a bit. And so studies have shown that this will even persist, this increased symptoms of psychosis will persist even after cannabis use ends. So as a teenager, well, and I should really say not just as a teenager, but up to about age 25, when the brain stops developing, it looks like cannabis use can actually cause psychotic symptoms, and that those psychotic symptoms, because they change the way that the cannabis use has changed the way that the brain develops, that those psychotic symptoms are persistent. So here are some examples of psychotic symptoms there. And then finally, what about a third variable causing both diagnoses, the diagnosis of severe mental illness, and then the diagnosis of SUD or a substance use disorder. So what we see, one possibility is what's called delay discounting. And this is just whether you can wait for a bigger reward or whether you'll take a small reward right now. So if I say, okay, well, you can have $10 right now, or you can wait a week and I will give you $30, okay? A lot of people will say, oh, I'll just take the 10 right now. And those are people that discount the delay. They don't think it's worth it to wait, basically. So it turns out that people with substance use disorder tend to prefer those immediate rewards, even if they're small, compared to a larger reward later. So they discount the delayed rewards. They just think, forget it. I'm not really into that. I'm not into waiting a week. That's not as important to me as in having it right now, even though it's smaller. So we get this kind of impulsive, and it makes sense because, there's an immediate reward of taking the drug, although there may be some good rewards for staying off of it. But a person with SUD tends to impulsively use the drug. So delay discounting is associated with substance use disorder. And with higher levels of discounting, we also see higher comorbidity with severe mental illness. So it seems like that delay discounting may, in fact, cause both disorders to happen. So that's an example of a psychological variable that may affect the causation of both disorders, both diagnoses. Okay, so objective number 3. We're going to, next time, identify effective treatment and treatment challenges in dual diagnosis. Until then, I will see you on the screen. Have a great day.